My coordinator here is, the whole program will be coordinated by Dr. Pradip Paria. We have 8 cases, so we can try to finish it by in time. And I'm inviting the President, Sushmita Banerjee, and a PGTI to write to fuller book. Madam, you can count in the class. What do you? I to write. Yes, Madam Sushmita Banerjee. Now I am inviting Madam Kalpana Datto, who is the President-elect. Hey, Pradip, hey, hey, Konok. I'm going here, so So I am inviting again Dr. Rakesh Mondal, who is the judge today. So I am inviting Somsubro Bose, who is again the judge today. So, so now we can start in our session. I'm handed over the mic to Dr. Pradip Paria, who is our coordinator.
Good afternoon, everyone. Welcome our dignitaries, the judges, residents, our colleague and my students and my friends. Today in IIP clinical meet, monthly clinical meet, we have 12 cases, and this is in a hybrid mode. Like in our setup, this will be in hybrid mode. I like to start with Dr. Madhurima Ganguly, our first presenter. Dr. Madhurima.
A very good afternoon, everyone. I am Dr. Madhurima Ganguly, Junior Resident of Pediatrics, and I would like to speak on polyuria in a sick neonate, a diagnostic dilemma. A 1500-gram old baby girl born at a gestation age of 33 weeks 2 days was referred to our institution at day 11 of life with the presenting complaints of lethargy, poor feeding, high-grade fever, and seizures. On examination, there was evidence of shock and poor respiratory drive. Immediately, the baby was shifted to neonatal intensive care and put under invasive mechanical ventilation. So, after the baby was shifted to NICU, polyuria was noted. Blood gas at the time of presentation was suggestive of hypernatremia, hyperkalemia, lactic acidosis, and increased serum osmolality. So we started resuscitation with fluids, and correction of electrolytes was started with monitoring of vitals and urine output. So far, so good. However, there was worsening polyuria. As noted in postnatal day 12, 13, and 15, urine output exceeded to more than 8 ml per kg per hour. So we have a sick neonate in shock with polyuria. What can be our differentials? It can be polyuric phase of acute kidney injury. It can be an RTA, neonatal diabetes mellitus, diabetes insipidus, primary hypoaldosteronism, after ruling out certain other causes like use of diuretics and rest.
The slide is not shifting. The slide is not changing. We are just viewing the first slide.
Sorry for the glitch.
You need to change the slides. We can't view the slides.
মেলোডি আপনি চেঞ্জ করে
হ্যাঁ, চেঞ্জ হচ্ছে।
এবারেতে ঠিক আছে, আপনি ফার্স্ট স্লাইডে চলে যান। হ্যাঁ, এবারে দেখা যাচ্ছে, ফার্স্ট স্লাইডে চলে যান ব্যাক করে। এটা তো স্লাইড নাম্বার 2 তে আছে, এখান থেকে বলতে শুরু করুন।
I'm really sorry for the technical glitch. I'm just trying to begin from the very first slide for the online audience. I'm sorry. A 1,500-gram baby girl born at a gestation age of 33 weeks 2 days was referred to our institution at day 11 of life with the presenting complaints of low-grade fever, lethargy, vomiting, poor feeding, and seizures. On examination, there was evidence of shock with poor respiratory drive. Immediately, the baby was shifted to neonatal intensive care, intubated, and put under invasive mechanical ventilation. After the baby was shifted to NICU, we noted polyuria. Blood gas at the time of presentation was suggestive of hypernatremia, hyperkalemia, lactic acidosis, and increased serum osmolality. So we started fluid resuscitation and electrolyte correction for the baby with monitoring of vitals and urine output. But so far so good. There was worsening polyuria. Mostly in postnatal day 15, the urine output exceeded more than 8 ml per kg per hour. And that was a real concern. So we have a sick neonate with shock with polyuria. What can be our differentials? It can be polyuric phase of acute kidney injury. It can be renal tubular acidosis, neonatal diabetes mellitus, diabetes insipidus, primary hypoaldosteronism. So we want to find out what was the cause of polyuria in our case. So we went for investigations. As evident in the slide, total leukocyte count was high, neutrophilic predominance with C-reactive protein and procal was raised. Renal function test was absolutely normal with normal liver function test. Blood culture was sterile. We performed a CSF study. CSF study was suggestive of meningitis with hypoglycemia and increased microprotein and increased cell type. So the urine analysis was normal. Ultrasound of whole abdomen with kidney and the adrenal imaging was also normal. So we wanted a master chart and we started mapping the baby from the postnatal day 12, that is at the day of admission and further. So as you can see that there is an increase in serum sodium with increase in serum osmolality, with decrease in urine osmolality, and in all the cases, the capillary blood glucose was normal. So to summarize, we have an early preterm IUGR low birth weight baby with late onset sepsis meningitis with refractory hypernatremia, polyuria, high plasma osmolality, and decreased urine osmolality. So in a nutshell, diabetes insipidus was suspected in our baby. We went for vasopressin challenge test. The following test protocol was initiated. Continuous IV infusion of aqueous vasopressin was given at the rate of 1 milliunits per kg per hour, and we measured the electrolytes along with the serum and urine osmolality on a 3-hourly basis. So what response we got after vasopressin challenge? As you can see in the postnatal day 16 after vasopressin challenge, the serum sodium decreased. Along with that, there was a decrease in the serum osmolarity with slight normalization of the urine osmolarity, and urine output also normalized subsequently. So we are now sure that we are dealing with a case of diabetes insipidus. Now, what is the cause of diabetes insipidus in our baby? So we went for cross-specialty referrals and we wanted to evaluate the hypothalamo-pituitary axis. The hormonal assays were normal. Then we planned an ultrasound brain, and the ultrasound brain was suggestive of ventriculitis as evident in the fibrous strands. So ventriculitis might be because of the complication of meningitis itself. So final diagnosis, we are dealing with a single live early preterm low birth weight child, possibly due to central diabetes insipidus and ventriculitis and meningitis. So we managed the child with nil per mouth and IV fluids. Invasive ventilation was given for 5 days, gradually weaned off. IV antibiotics were given for a total of 6 weeks. Vasopressin was given for 5 days and also supplemental free water for subsequently 7 days. Initially, the baby is lost to follow. We planned for an MRI brain, but it was not possible because of the loss to follow. First follow was done at 2 years, 1 month. The baby had normal development, normal neurological parameters with normally gaining weight. The MRI brain was normal with normal serum and urine osmolality. So this is the MRI brain that we did at our follow-up. This is the pituitary section, which was absolutely normal. So let us go to the discussion. Neonatal central diabetes insipidus is extremely rare with an approximate incidence of 2 per 1 lakh live births. And the diagnosis is definitely very challenging in neonates because of the insensible water loss, which can be contributed as the cause of hypernatremia. So there are various case reports and publications which exhibit the rarity of our case and the diagnostic challenges. So far, we have 17 cases of meningitis, which are causative agent of central diabetes insipidus in newborns. So what is my take-home message? Neonatal diabetes insipidus is a diagnostic and therapeutic challenge to all neonatologists. Prompt evaluation of a persistent hypernatremic neonate can be a life-saving measure, and it actually renders a very good outcome, as was evident in our case. Thank you.
Thank you, Dr. Mohdri, for nice presentation.
2 years, 1 month. No, not on vasopressin. It was a transient case of diabetes insipidus that we encountered in NICU. And we thought of finding the etiology, and that's why we did all the hormonal assays and the ultrasound brain. Most probably at that time, the cause of central diabetes insipidus was meningitis. And that was also evident from our CSF study. And later on, we did an ultrasound brain. And ultrasound brain was also suggestive of ventriculitis. Though there are no case reports of ventriculitis causing central diabetes insipidus, but we can say that ventriculitis is a cause of meningitis, complication of meningitis. And that has rendered the outcome, that is the central diabetes insipidus in the neonate. And later on, we followed the baby. Initially, it was lost to follow-up, and later on, when we did the MRI imaging, as I showed in my slide, it was absolutely normal, and the baby had no complications. Usually, in case of neonates, if we usually it is renal, because it can be because of receptor defects and in the kidney. Yes, I have seen 2 cases of in case of pediatric population only in our PICU, but that was also central diabetes insipidus because of cerebral malformation, holoprosencephaly. Yeah, it was post. One was holoprosencephaly and one was after IVH, intraventricular hemorrhage. Okay.
Thank you, Dr. Mutrima, for nice presentation, and thank you, judges and dignitaries, for questions, and she gave the answer correctly. Our second case will be delivered by Dr. Sukanya Dev. Her topic is a swollen saga. Dr. Sukanya, please.
A very good afternoon to all. I am Dr. Sukanya Dev, third year pediatric resident. Today, I would like to tell you a story of a swollen boy. My child is an 11-year-old boy who presented to us with diarrhea and vomiting for a period of 7 days, low-grade intermittent fever for a period of 3 days, gradual progressive swelling of face followed by legs for a period of 3 days, and decreased urine output for same duration. There was no history of sore throat, cold, cough, no history of skin rashes, any skin infection, no history of dysuria, abdominal pain, flank pain, and no history of any previous such episodes in past. On examination, the child had periorbital puffiness, facial swelling, bipedal edema, and the child had pallor. We proceeded with the urine examination. Which showed cola-colored urine and heat test was 3+. On routine and microscopic examination, albumin was 3+, plenty of RBCs were found, and what we found were dysmorphic RBCs. On blood investigation, what we found was urea creatinine was significantly raised and the child was oliguria. The child had hyperkalemia, anemia, and thrombocytopenia. So the child presented to us with acute kidney injury, hemodialysis was done, and AKI management was given. So what are we dealing with? A child with this clinical history presented with glomerular hematuria, proteinuria, and presented with acute kidney injury. So, is this a case of hemolytic uremic syndrome? Or it is a case of post-infectious glomerulonephritis? Or a membranoproliferative glomerulonephropathy, C3 glomerulopathy, IgA nephropathy, or rarely Alport syndrome? On the clinical progression on day 2, the child was found to be hypertensive, was accordingly managed, urea creatinine was raised, and the child was oliguric. Day 3, the similar story persisted, and the child had to undergo second episode of hemodialysis. With this rapid deterioration, the diagnosis of rapidly progressive glomerulonephritis was made, and the child was started on pulse dose of methylprednisolone. Meanwhile, we had rest of the investigations in our hand. C3 was low, C4 was normal, ASO titer was normal, though no growth was found on throat culture. The child was anemic, thrombocytopenia was there, but no cystocytes were seen in peripheral blood smear. And the rest investigations are as shown, and nephrotic range proteinuria was there. With the clinical background of RPGN in our mind, with low C3, is it a case of poststreptococcal glomerulonephritis? But no history of sore throat was there, and ASO titer was normal. Or it is a case of membranoproliferative glomerulonephritis, C4 was normal. Or with the background of anemia, thrombocytopenia, and presentation of renal failure with low C3, atypical hemolytic uremic syndrome could be there. Or C3 glomerulopathy was the cause. There was a rapid deterioration. By the end of the first week, the child had to undergo 2 more episodes of hemodialysis. Day 8, the child became hemodynamically unstable. Urea creatinine was raised, was oliguric. Day 9, the same story, and 5th episode of hemodialysis had to be done. At day 10, there was no clinical improvement. Polar colored urine persisted, edema persisted, urea creatinine raised, oliguric. The child was anemic, but what we saw was the platelet count was increased. On day 12 and on day 14, the child had to undergo 2 more episodes of hemodialysis, and the child had to undergo, we planned for renal biopsy, and renal biopsy was done. Day 16, platelet count showed an increasing trend. Day 21, that is at the end of the 3rd week, the urea creatinine started normalizing. Gross hematuria was absent, urine albumin was 3+, and facial puffiness mildly resolved. By the end of the 4th week, the puffiness resolved, hematuria, microscopic hematuria persisted, and proteinuria was absent. So now after that, what we had in our hand was the report of renal biopsy, which showed that this is a case of acute post-streptococcal glomerulonephritis. We followed the child. At 2 months follow-up, the child is well. C3 is normal, no proteinuria, no microscopic hematuria, and ASO titer was positive then. RFT was normal. The child was again followed up at 6 months, and the investigations were normal. So this is a case of acute post-streptococcal glomerulonephritis with its extremely rare manifestation of acute kidney injury and atypical feature of thrombocytopenia. So we did some literature review, and we found that such presentations have been previously reported as well. These are few case reports where thrombocytopenia has been reported with PSGN, where immune-mediated platelet destruction has been hypothesized as the cause. This is a clinical study done in southern India where 83 children with acute glomerulonephritis were studied. 20% presented with AKI, and only 1 child was there in stage 3 AKI and required hemodialysis. So I would like to conclude that PSGN is usually a self-limiting disease and has a milder course, but it can also present with complications of cardiac failure, PRAS, encephalopathy, acute kidney injury as in our case, and atypical features of thrombocytopenia and hemolysis has been reported as well. Thank you. Yes, sir. Yes, sir. Yes, sir. Sir, actually the presentation with the diarrhea and vomiting, we thought it to be typical HUS, but when the C3 came low, the atypical HUS was thought. So other antibodies such as the factor H antibody and factor I antibody and other CD46 protein level should be done. But actually, because of the financial constraints, it couldn't be done. And it is also seen that in some cases of atypical HUS also, there is a previous episodes of febrile illness or respiratory illness has been reported. Yes, ma'am. Yes, ma'am. Yes, sir. Yes, ma'am. Yes, ma'am. Yes, sir. The child is in follow-up 6 months, and now it is 9 months. So he comes to our OPD regularly. No, ma'am. There were no presents found. Yes, ma'am. Yes, ma'am. No, ma'am. Ma'am, so we just thought that it is a PSGN with the clinical progression was that of Harpijan. That's why we started with the steroid. Yes, ma'am. Yes. Yes. Yes, ma'am. Yes, ma'am. Yes, ma'am. As the biopsy was not supportive of HUS, there was no endothelial widening and no debris seen. So we favored more towards PSG and the yes, ma'am. We have to follow up and the antibody. Yes, ma'am. Okay, ma'am. Thank you, ma'am.
Thank you, ma'am, for your valuable input. We will follow up the patient in our setup for the further prognosis and further immunosuppression if needed or not. Thank you, Dr. Suparna, for nice presentation. Our third case will be presented by Dr. Shreya Datto. Our presentation is on pediatric ascites revisited. Dr. Shreya.
Good afternoon, everyone. I myself, Dr. Shreya Datto, PGT in the Department of Pediatrics, going to present an interesting case, pediatric ascites revisited. A 10-year-old girl. A 10-year-old girl presented with pain abdomen for 3 to 4 months, general swelling of whole body for 2.5 months, history of low-grade fever for 15 days, 1 month back. No contact history of pulmonary tuberculosis. No history of jaundice, prolonged diarrhea, decreased urine output. Vital signs were all normal. On systemic examination, abdomen distended, sweet chill present. There was no organomegaly. Height and weight was less than 3rd percentile. What will be the probable cause? Tubercular peritonitis, constrictive pericarditis, Budd-Chiari syndrome, or pancreatic cause of ascites. Coming to laboratory investigation, routine bloodstone, renal function tests were all normal. Liver function tests were normal. All other enzymes are within normal limit, except albumin, which was 3 grams per day. Lipid profile was normal. Serum amylase lipase was significantly elevated. 225 units per liter and 730 units per liter respectively. 7 at phosphotam negative, echo normal study. Multiple times abdominal paracentesis was done. Fluid analysis demonstrated the following. Gross appearance, which was mild hemorrhagic, albumin 2 gram per dl, SAG 1, amylase and lipase were 7,000 and 380 units per liter. Coming to radiological investigation, USG whole abdomen shows only massive ascites. CCT whole abdomen reveals gross ascites, mild pancreatic parenchyma thinning with prominent pancreatic duct, likely chronic pancreatitis. Upper GI endoscopy was normal. In MRCP, there is a non-uniform dilatation of main pancreatic duct in entire length, features suggestive of chronic pancreatitis and gross ascites. So my diagnosis is a case of pancreatic ascites due to chronic pancreatitis. As my patient is having pain abdomen for 3 to 4 months, this is a case of low sag ascitic fluid, serum and ascitic fluid, amylase and lipase were raised, CCT and MRCP suggestive of chronic pancreatitis and gross ascites. Treatment given injection octreotide subcutaneously, IV antibiotics, IV diuretics, human albumin, TPN started. Multiple times therapeutic paracentesis was done. Due to recurrence of ascites, she developed high-grade fever, decreased urine output, shock, hematuria, icterus, bilious vomiting, suggestive of sepsis. So TPN was stopped, antibiotics upgraded, inotrope supports given, vitamin K given, FFP and PRBC transfused. Gradually patient improved, infection controlled, ascites was reduced, again TPN was started and continued for 10 days, along with multivitamin and PPI. After 2 weeks of PICU stay, patient became hemodynamically stable with persistent of ascites, then referral discharge to pet gastro department of SSK for ERCP and further management after 1 month of conservative therapy. On follow-up, after 1 month, the child is doing well with resolution of ascites without endotherapy. Coming to review of literature, pancreatic ascites is not only a rare cause of ascites per se, but also an uncommon complication of pancreatitis in children. Massive pediatric pancreatic ascites is usually caused by chronic pancreatitis or traumatic pancreatic duct disruption. A course of conservative medical management leads to recovery in approximately 30 to 50% of patients. Endoscopic placement of a transcapillary stent appears to have a success rate of 80 to 100%. When medical and endoscopic management fail, a surgical approach is often taken with reported mortality ranging from 15 to 25%. So my take-home message is, when there is ascites with abdominal pain, we should do diagnostic paracentesis. We have to do both serum and ascitic fluid, amylase and lipase to rule out pancreatic ascites. We have to do conservative management. If not respond to conservative management, then surgical intervention should be considered. Thank you. Tropical pancreatitis.
That's the important, I think that's the important indicator. And here we are supposed to do what correctly. This is important. But they usually have hypertension. Upon my knowledge. Second thing, you getting entered into was supposed to rule out another thing here. Other clinical factors. I don't know, this can go on like
Yes.
Thank you, Dr. Shreya. Our next presenter, Dr. Sharmishta. Our topic is All is Not Well, a Facet of Vision. Dr. Sharmishta.
A very good afternoon to all of you. I'm Sharmishta Chaudhary, resident of Pediatric Surgical, and I'm here to present to you a twisted journey of ophthalmoplegia, which was nothing short of a facade of vision. So what had caught our eyes first? This was about a 10-year-old girl child presenting to us with complaints of double vision on and off with episodic difficulty to lateralize the right eye for a month. On examination, the cognition was normal, the vitals were stable, there were no neurocutaneous markers, no meningeal signs, no bony tenderness, and the pupillary reflexes were normal. The only abnormal finding was restricted abduction of right eye, suggestive of lateral rectus palsy. No other neurological deficit could be delineated, and the jerk and reflexes were normal. So, before presenting to us, the child already had sought treatment somewhere else. How it had all started 6 weeks back. It all started with a pain and dysesthesia, which first started over the right wrist, associated with a transient non-progressive weakness, which was soon followed by a similar pain and weakness on the right dorsum of the foot. Over the next few days, the child started developing a neck pain with low-grade intermittent episodes of fever and occasional episodes of headache. As soon as the fever resolved, the child started complaining of episodic double vision with difficulty in lateralization of right eye. As we delved deeper, there was no history of rashes or prodromal symptoms, trauma, weight loss, sensory or sphincter involvement, and any such episode before. There was no history suggestive of transient ischemic attacks, no hypertension, no cardiac disease. There was no history of contact or exposure to TB, and the family history and birth history were insignificant. As we unearthed the previous reports from outside, the routine investigations were completely unremarkable. Complete blood counts, ESR, peripheral blood smear were normal. X-ray of chest, ECG, X-ray cervical spine, and wrist and foot were all normal. Triple serology was negative, and coagulation profile was normal as well. The previous MRI reports suggested patchy demyelination in frontal white matter and distended right optic nerve sheaths. However, no extraocular muscle infiltration or any space-occupying lesion could be delineated. The child had been provisionally diagnosed back then as right lateral rectus palsy following viral fever and was discharged with oral steroid and was planned for follow-up in 2 weeks. 3 weeks later, after an initial resolution of the symptoms, the child presented to us with episodic squinting of right eye again. So, to summarize, we had a neurodevelopmentally normal girl child who presented to us with complaints of double vision, with fever, neck pain, and dysesthesia of the extremities at the onset of the double vision. Along with that, MRI finding of demyelination were there. So what were we looking at? NMO spectrum disorder, multiple sclerosis, clinically isolated syndrome, CNS vasculitis, or just raised intracranial tension. So following the same trail, we got the routine investigations repeated. Serum for which were absolutely normal. Serum for ANA, ANCA, anti-dsDNA, RA factor were negative. Anti-aquaporin 4, anti-MOG antibody were ruled out. Repeat MRI brain revealed no significant abnormalities. The previous lesions were resolved and the optic nerve sequences were somewhat normal. MRI spine was done, which revealed bulging at C5, C6 level with no areas of demyelination whatsoever. EEG was normal. So we got a fundoscopy done, which revealed this picture of severe papilledema bilaterally. The visual above potential test revealed delayed P100 latencies in right eye, suggestive of right-sided demyelinating optic pathway dysfunction defect. So 2 roads diverged in a yellow board, and I'm sorry, I couldn't travel both. So there was a clinical dilemma between idiopathic intracranial hypertension and the demyelination syndromes such as optic neuritis or NMO spectrum disorder. To get a clarity in the picture, we got a CSF study done, which further clouded the picture more. The CSF opening pressure was raised with 42 millimeter of mercury, and it revealed a pleocytosis of 400 with a predominance of 95% of lymphocytes. However, there were no atypical cells. The protein was mildly raised, sugar was normal, and oligoclonal band pattern was not found. ADA was negative, and gene export was negative as well. So our differentials of idiopathic intracranial hypertension was ruled out since we got a CSF pleocytosis of 400. Demyelination was ruled out as well, and being in the gray zone, we had to come up with a provisional diagnosis of chronic meningitis. The child was provisionally diagnosed as a case of chronic meningitis and was started on antitubercular drugs therapy. Acetazolamide was started along with steroid, and the child was asked to follow up 2 weeks later. After 2 weeks, CSF showed a dramatic resolution with cell count of 5 cells. Culture and staining showed no Cryptococcus, Candida, or Acanthamoeba whatsoever. No acid-fast bacilli was demonstrated, no atypical cells were seen. Interestingly, the squinting disappeared and the papilledema resolved as well. So the ADD was continued until after a month. The child reported with sudden onset purpuric spots along with no episodes of overt bleeding still. On examination, cognition and higher functions were normal. The child had no signs of pallor, lymphadenopathy, no signs of any organomegaly, no bony tenderness, and the tourniquet test was negative as well. We again faced a clinical dilemma between these 3 things: ITP, malignancy, or whether it was a drug-induced purpura. We repeated the routine investigations. The complete blood picture this time revealed a severe thrombocytopenia of 10,000 and lymphocytosis of 68% with abnormal precursor cells and some atypical mononuclear cells as well. ESR was still normal, LDH was raised, ferritin was within normal limits, uric acid was not raised, and the coagulation profile was absolutely normal. The sudden ominosity conferred by the investigations, which were previously normal, raised an alarm of a bumpy road ahead. So the drugs like the ATD and the acetazolamide, were discontinued. The child started developing pallor of acute onset with overt signs of bleeding during the hospital stay. She also started having high-grade fever, 2 episodes a day. The child was managed aggressively with blood transfusions and was planned for bone marrow biopsy. Serial blood counts, however, revealed emerging pancytopenia over a span of 1 week. The child was admitted in ISTM and a bone marrow biopsy was done. The bone marrow says it all, or rather uttered better as ALL. So the features were consistent with pre-BALL, and cytogenetics results revealed a translocation of 922. The child was started on chemotherapy regimen. However, all didn't end well. The child had to be shifted to pediatric ICU and was electively intubated due to profuse hemoptysis. Chemotherapy was continued, and along with blood transfusions, however, the child succumbed to the comorbidities. So, sir, medical policy. No, ma'am. Yeah. So the literature review, eyeing the cases around the world, there are only 2 or 3 such cases reported all over the world in which ALL presented with features of raised intracranial tension. And the diagnosis could not be ascertained because of the absence of the leukemic infiltration of the CSF or the peripheral blood smear. Take-home message, albeit with a heavy heart, CNS involvement at the presentation time of ALL may occur in 5 to 7% of the cases, and raised ICT as an isolated finding of ALL may occur prior to appearance of hematological manifestations, and this may get delayed by months, hence need to be worked up well. Sentinel demyelination, as in our case, could not be ascertained to a particular etiology and still remains an enigma. So a high degree of clinical suspicion might help in such varied presentation. Lastly, I would like to say, in the road of medicine, patients are our best teachers, the ones we treat and save, more so the ones we lose on our way. CBNAT reports were negative, but since the from CSF also, yes, ma'am, gene expert was done, CSF was negative for CBNAT. Yeah. So it was ruled out in the course of in the due course. Actually, the child was evaluated earlier in the child was initially treated at some other institution. Actually, when the child presented to us, the child had only features of squinting. There was no fever or pain or dysesthesia whatsoever. So as we, ma'am, in this case, it was just 4 months. Within a span of 4 months, the picture transitioned that abruptly. Platelet count, sir, it was within normal limits, 2,50,000 around. I can. Sir, it was about 3.5 months, 3.5 to 4 months. Yes, sir. Yes, sir. Exactly. It got altered. It might have got altered because of the steroid. But sir, since the very beginning, the child had received steroids. We couldn't get a previous picture typical of ALL. Since the demyelination was present. Sir, repeat CSF. So we were trying to look out for any etiology for which the child presented with these clinical presentations. The squinting, it had to be whether there was any chronic.
Chronic meningitis, ma'am. Yes, ma'am.
Actually, at first presentation also we can go through the.
Actually, the very first presentation was being evaluated outside. So the child had already received steroid and then she came to us, so the entire picture got changed. However, due to the demyelination picture, what we got over there, we had to continue with the steroids, and the raised ICT also suggested us to go with the same treatment as well. Yes, sir.
Thank you, Dr. Sulmishra, for nice presentation. I would like to invite Susmita ma'am or WBAP president for announcement.
Actually, we are celebrating the What is Week. I think all hospitals, there are some ways they are celebrating, and tomorrow we are celebrating the What is Day itself, and that will happen in Chittaranjan Shishu Sadhan. So we requested everybody for a team to go for a quiz competition. I think you have selected your team, somebody is going. And day after tomorrow and Sunday, we are celebrating ending the What is Week with a big gastro program. So we are inviting 8 national faculties and 1 international faculty to glorify this occasion. So I would request all the PGTs to attend, because there will be very, very good important discussions which will be very important for your examination as well, and for the practical part of your patient management. So I would like to request Dr. Govinda to motivate all of them. So it's very easy. You can just go, and when the spot registration is the same, and it's only 1,000 rupees for the juniors. So I think I would like to invite all of you cordially to attend the seminar and make it a success. Those who have yet not registered, they can always attend, because in the morning you can do your rounds, finish your work. It will all start at 1 o'clock. So you start with lunch, and then after that you arrange, and then after just evening we will end by 6:30 the program, and little bit of cultural and the mental magic by a very young candidate like you. And then we will end up dinner very early, 7:30 we will end up. So after that you can finish your work, and in the next morning you can finish your you can give an early morning round and start at 9, and by lunchtime we will all finish. So it won't hamper your day-to-day work as well. So please, please, please come and glorify our occasion. Thank you. Thank you.
So we have a busy weekend planned, so please do join us. I think the programs will be very nice. So that was the ORS Day program in Chittaranjan Shishu Sadhan on the 29th and 30th, 31st in Swabhumi. Please join. Following that, the next week is the breastfeeding week, 1st to 7th August. And I know that all the institutes will have their own programs. Whatever programs you have, Dr. Dash, ORS Day, ORS week, breastfeeding week, Jaigule CIP program, if you can send us some photographs and a little write-up, we will include it in our annual report that these are all programs that our members in West Bengal are conducting. So please remember and send. Breastfeeding week from the from WBAP, we are celebrating this this time in RKM, Ramakrishna Mission Hospital, on the 4th of August, and we will send you the detailed program. Please, Kalpunadi, Rakesh, Shomshubra, please ask all your colleagues and students for the breastfeeding week celebration on behalf of WBAP in RKM Hospital. Okay, program details. The next clinical meetings are 11th August in Krishnanagar District Hospital. So from I think most of us from Kolkata will be joining online. So we will send you the link for that. And 25th August in NRS. Okay, so please come. And Shomshubru will tell us about the Journal Club, which is a new venture of WBAP. We are conducting online throughout this year. So Shomshubru,
এখানে
Good afternoon, everyone. Nice cases. Till I listen now. I have to leave for my some urgent work. So I want to announce there is a National Tuberculosis Elimination Program on 6th of August at Medical College. Registration is free. But there's along with the asthma conference, who are interested in asthma, they can do the registration for 1,000. But I'm asking for NTP. But you have to send the name only. Phone number and mail. It is registration is free. And every pediatrician must know, rather every medical officers, physician must know about the elimination of program. That's very important. And on 2nd September, 3rd September, 4th September, conference on developmental pediatrics. As a part of that, there will be early child development nurturing care. That is also very important and very beautiful module. And this, on the 2nd, it will be in the medical college. I'm coordinating. I'm welcoming all of you. Please register in the both NTP and early childhood development nurturing care. Thank you.
Yes, a small announcement that we'll have our 3rd journal club session on 17th August. That's a Wednesday, and it will be an online program. It will start from 8 p.m. onwards, and this time National Medical College and Bhagwan Medical College, both of them will participate. We will have the speakers with the moderators, and this program is mostly designed for the postgraduate student, and we hope that we should all be present in a large number. Thank you.
Thank you. Our next speaker, Dr. Preeti Mojumdar, our case on unraveling a case of chronic malnutrition. Dr. Preeti.
Good afternoon, everyone. Myself, Dr. Preeti Mojumdar, 3rd year postgraduate trainee in Department of Pediatric Medicine at Radiological Medical College. Today, I'm here for unraveling a case of chronic malnutrition. A 2-year, 7-month-old girl belonging from our lower middle socioeconomic class presented to us with complaint of intermittent history of vomiting since last 2 years, which aggravated since last 10 days. There was multiple episode of loose stool since last 5 days, severe weakness since last 4 days, and documented low blood fever since last 3 days. From past history, it was known that there was one-time hospital admission for 10 days due to acute gastroenteritis and severe dehydration at the age of 1.5 years. From birth history, it is known that there was essential admission for 12 days due to very low birth weight, preterm delivery, and mother also gave history of having polyhydramnions. Dietary history up to 6 months exclusively breastfeed. From then, complementary feeding was established. On presentation, the child was lethargic, features of dehydration was present, the child was normocardiac, normotensive, euglycemic, afebrile, and there was no sign symptom of respiratory distress. From anthropometry, height and weight was below 1st percentile, head circumference was below 3rd percentile, and mid-upper arm circumference was below 11.5 centimeter. So we provisionally diagnosed that it was a case of acute gastroenteritis in a case of chronically malnutrited child. ABG revealed hyponatremia, hypokalemia, and alkalosis, and the child was treated as per protocol. Relevant primary investigations including blood test, chest X-ray, urine, and stool routine examination, everything was normal. So what is the cause of growth faltering in the child? The causes may be divided in 2 groups: organic cause and non-organic cause. In the non-organic cause, I would like to mention poverty, lack of knowledge during adequate dieting, and dysfunctional parent-child relationship. And it is also known that non-organic cause is the most common cause of growth faltering. Every organ system can be involved in causing growth faltering, and after taking adequate history, clinical examination, and laboratory investigations, we ruled out many organic causes. On the 2nd week, day 13, 15, 16, 17, we found that there was metabolic alkalosis with hypokalemia, hypochloremia, and PCO2 was in the upper normal level. Some important findings in our child that I would like to mention that there was infantile origin of the symptoms. Maternal history of polyhydramnios was present. There was history of recurrent polyuria, polydipsia, dehydration, and the child also was having salt cravings. BP was normal on every measurement during the hospital stay. Now, some two important clues that will help us to reach our goal, that is to diagnose the cause of growth faltering in this case. One is persistent metabolic alkalosis with hypochloremia, hypokalemia in the second week when loose stool and vomiting had subsided, and second is normal blood pressure. The causes of metabolic alkalosis with hypokalemia, it can be again divided in two groups: chloride resistive group and chloride responsive group. Chloride responsive group where urinary chloride is less than 15 milliequivalent per liter, and chloride resistant group where urinary chloride is more than 20 milliequivalent per liter. In the chloride responsive group, three important causes: cystic fibrosis, gastric losses, and congenital chloride losing diarrhea. In the chloride resistant group, child having hypertension, the causes may be renin secreting tumor, primary hyperaldosteronism, and renovascular disease. And child having normal blood pressure, three causes are important, that is Bartter syndrome, Gitelman syndrome, and diuretic abuse. We ruled out diuretic abuse, and it is also important to note that the child was having persistent normal blood pressure. So urinary chloride in our child was 29 milliequivalent per liter, and sweat chloride test was also negative, so we ruled out cystic fibrosis. Now, is it Bartter syndrome or Gitelman syndrome? As we know, Bartter and Gitelman are two phenotypically identical syndromes, and infantile origin of the symptoms, maternal history of polyhydramnios, hypochloremia, it is absent in Gitelman syndrome, present in Bartter syndrome. Severe failure to thrive, it is present in Bartter syndrome and very unlikely in Gitelman syndrome. We investigated further and we did serum magnesium, urinary calcium, and USG-QB region. Serum magnesium in our child was normal. In Gitelman syndrome, always hypomagnesemia. In Bartter syndrome, most of the cases, magnesium is normal, but there are some cases where hypomagnesemia may be found. Urinary calcium in our child there was hypercalciuria. In Gitelman syndrome, always hypocalciuria. In Bartter syndrome, hypercalciuria is present. USG-QB in our child, there was nephrocalcinosis, which is absent in Gitelman syndrome, but in type 1, type 2 Bartter syndrome, it is very common. So urinary calcium in our child was 10 milligram per kg per day, and the normal value is less than 4 milligram per kg per day. Serum magnesium was normal and USG-QB nephrocalcinosis. So the child has Bartter syndrome, and we further performed BP and BERA to rule out if SNH, sensory neural hearing loss, is absent or present. And we found that there was absence of sensory neural hearing loss, but there was a coincidental finding on BP, that is bilateral optic pathway demyelination. Now, what type of Bartter syndrome? As sensory neural hearing loss was absent, so we can say it was not type 4 Bartter syndrome. Now, is it type 1, type 2, or type 3? The only confirmatory diagnosis can be made after doing genetic testing. And here I would like to mention that I have sent blood for genetic testing and report is pending. We started treatment with tablet indomethacin at the rate of 2 milligram per kg per day. So before starting indomethacin, when the child was on oral potassium chloride supplementation, the potassium was 2.72, pH was 7.523, bicarbonate 32.7, and PCO2 40.7. After 4 days of starting indomethacin therapy, though there was presence of metabolic alkalosis, but potassium was 3.4 and chloride was also normal. After 7 months of treatment with indomethacin, here is our child. Though height and weight still is below first percentile, but there is gain of 6 centimeter height in last 7 months and 5.5 kg weight gain in last 6 months. Blood gas is now normal. So we can see there is considerable improvement in the child in the height, weight, and both the well-being. So my take-home message, whenever a child present to us with growth faltering, we should be very careful regarding the blood gas parameters and blood pressure of the child. We should take the antenatal and habitual history of the child very carefully. And in acute gastroenteritis, in initial condition, we may found metabolic alkalosis, but we should be repeating the VBG or ABG even when the acute crisis is over, so that we don't miss such cases. Though Bartter syndrome is a rare cause, 1 in 10 lakh population, we should keep it in mind in differential diagnosis of metabolic alkalosis in a child with failure to thrive. Because the defective defective functions of the tubular cell in the kidney, it cannot be corrected, so treatment is lifelong. Adequate timely diagnosis and management of the child can help the child to live a normal, healthy life. Aim of a treatment to correct hormonal, fluid, and electrolyte abnormalities. Thank you. Sir, we have sent blood in the private setup in the Life Cell Diagnostic Center for whole genome sequencing, and we have been focusing for type 1 mutation where NKCC2 gene is involved, in type 2 where ROMK gene is involved, in type 3 where BSDN gene is involved. Sir, 12,000. Sir, if the case is proven genetically, then as it is an autosomal recessive disorder, we can counsel the parents regarding the
There must be registry development. There is such in India or
sir.
In India, sir,
we are usually
No, no, ma'am. This is the first child. Sir, ma'am, we have counseled the parents that the treatment is lifelong and the child should be taken to us for follow-up regularly, because there anytime there may be electrolyte disbalance, dehydration, so we have to check the child in monthly visits. And as we are sir, antenatal, ma'am, antenatal checkup hoy, amniotic fluid.
what is the possibility and what is the chance of
something new. That's the what is the line?
So if the child is treated with treatment and the life expectancy is good prognosis. %25% cases. Sir, ma'am, at this time the child is only on indomethacin therapy, no supplementation. No.
Our next presenter, Dr. Ayan Das. His topic is a cautionary tale on hematomegaly. Dr. Ayan. A very good afternoon to all of my respected teachers, seniors, juniors, and dear friends. I am Dr. Ayan Das, and I would like to present a cautionary tale of hematomegaly. A 3-year-old girl came to our pediatric emergency with first episodes of blood vomitus. There were 2 such episodes in home and 1 such episode in emergency triage. Volume was of 200 ml each. It was bright red in color along with clots. There was no history of fever, abdominal pain, jaundice, or coagulopathy. No history of dyspepsia, easy bruising, or bleeding from any other side. Neither there was any history of burns, septicemia, head injury, any drug intake, or any contact with tuberculosis. The child was second born to a non-consanguineous marriage, delivered at term. There was a history of delayed separation of umbilical cord. By day 25, persistent watery discharge from umbilicus till day 25 of life. However, there was no features of omphalitis or any history of umbilical venous catheterization. Only notable clinical findings were severe pallor along with features of shock. Anthropometry revealed both height and weight for age less than first percentile. Systemic examination revealed distended abdomen with splenohepatomegaly. Spleen was 7 cm, liver was 5 cm firm with enlarged left lobe, along with features of ascites and prominent abdominal veins. So, where we stand? From history and clinical examination, we can say that our child has significant hematemesis with splenohepatomegaly with features of portal hypertension and obviously no jaundice. So most probably we are dealing a patient with variceal bleeding. So what are our differentials? It may be due to extrahepatic portal venous obstruction. It may be due to cirrhosis. It may be due to non-cirrhotic portal fibrosis, or maybe due to congenital hepatic fibrosis, or maybe due to Budd-Chiari or glycogen storage disease type 4. That means Anderson disease. So in triage, we manage the child as per protocol, IV pantoprazole, octreotide along with antibiotic cefotaxime given. Blood investigation revealed significant anemia. Hemoglobin was 4.8 along with thrombocytopenia. Urea creatinine was level of urea creatinine was increased, but liver function test, blood electrolytes, urine samples, and serology was negative. There was also no evidence of coagulopathy. We transfused 2 unit PRBC and the post-transfusion hemoglobin was 8.6. Ascitic fluid analysis showed low protein high sac value. Upper GI endoscopy revealed large esophageal varices, grade 3. Sclerotherapy done with 100% ethanol. Endoscopic variceal ligation would be a better option, but as our child is only 3 years of age, the bands could not be negotiated further. Both USG Doppler and CT abdomen corroborated with our clinical findings, that is ascites and hepatosplenomegaly. But interestingly, there was bilateral nephromegaly along with cyst. Bone marrow revealed reactive picture. However, kidney biopsy is still pending. So let's recapitulate. Our child is a 3-year-old child with painless hematomesis, esophageal varices, splenohepatomegaly, portal hypertension, along with normal LFT and features of polycystic kidney disease. So we can say that our child has portal hypertension due to intrahepatic cause with features of polycystic kidney disease. To confirm our diagnosis, we did liver biopsy and it shows congenital hepatic fibrosis. So our child has congenital hepatic fibrosis with radiologically proven polycystic kidney disease. Now some literature review. Congenital hepatic fibrosis is a rare autosomal recessive disorder affecting both hepatobiliary and renal system. We can say that it is a part of fibropolycystic disease, which has association with both autosomal dominant and recessive polycystic kidney disease, along with as Caroli's disease. It is usually present in neonatal period. However, delayed presentation in late childhood are reported. Our child is only 3 years of age. Most patients do well if we control the variceal bleeding and there is no features of renal failure. But unfortunately, 25% patient die due to renal failure. Discharge and follow-up. The child was discharged on oral tablet propanolol, repeat upper GI endoscopy, followed by sclerotherapy done after 2 weeks and 6 weeks. Unfortunately, the child was again readmitted in February of this year for hematemesis. This time there was also presence of splenohepatomegaly, but no ascites was there. Upper GI endoscopy again revealed grade 3 esophageal varices and sclerotherapy done with 100% ethanol. Currently, the child is on oral propanolol prophylaxis. Upper GI endoscopy done every 12 weeks. So, what is my take-home message? Variceal bleed is a common cause of major upper GI hemorrhage. Hemodynamic stabilization is the immediate goal of treatment. Octreotide and upper GI endoscopy plays a major role. But I would like to end my talk with a cautionary note that apart from commoner causes, common manifestation of uncommon causes like congenital hepatic fibrosis should also be kept in mind. Thank you. Sir, thrombocytopenia maybe due to features of hypersplenism, because in this case hypersplenism may actually, sir, there is bicytopenia. Hemoglobin value is also decreased. Okay, sir, and I think, sir, the platelet value decreases due to features of hypersplenism. Sorry, madam. Autosomal recessive polycystic. Ma'am, we have to do PKD1 gene analysis and chromosomal analysis. Parents, yes. Yes, madam. 3 years old. And sometimes it may be revealed, but I don't know exactly development. Okay. Okay. Congenital hepatic fibrosis. So it is autosomal recessive PKD is more usually associated with congenital hepatic fibrosis, but Caroli's disease and autosomal dominant PKD may also be. Previously was high, but in day 4, the value gradually became normal. EGFR, madam, actually in initial setting it was deranged, but after subsequent treatment it gradually. Yes. Body weight and age and sex. Okay, madam. Yes, ma'am. Yes, sir. Sir, actually in literature, sir, actually in pediatric populations, sir, still literature says that IV octreotide is a drug of choice for always faster. Yes, ma'am. Sir, madam, maybe I don't know, but maybe it is due to features of
chronic liver disease or Okay. During acute bleeding, ascites. ESBB, yes, madam. Ascites may be present. Transient ascites. Okay. Thank you.
Thank you, Dr. Royal, for nice presentation. Our next topic is uncovering the weakness of a young boy, will be delivered by Dr. Sampurna Rai. Dr. Sampurna.
Very good afternoon to everyone. Today, I, Dr. Sampurna Ray, the pediatric resident of Archikar Medical College, is going to share this topic of uncovering the weakness of a young boy. Let the anecdote begin. A 11-year-old boy complained of pain, swelling, and redness involving the bilateral knee joint, bilateral ankle joint, and sacroiliac joint for the last 2 years, along with restriction of movements. This was also associated with with episodes of fever, which recurred every 1 to 2 months and was not relieved on antipyretics. So, are we dealing with a case of GI? We need to review the criteria for which we had, we're saying the following criteria: that age of the patient less than 16 years, duration more than 6 weeks, arthritis affecting more than one joint, and infections to be ruled out. There was no history of tuberculosis, no history of conjunctivitis, and dysuria. So now let's think of that our patient presented with such a history, which I've mentioned before. We can also think of the patient having systemic onset GIA or SOGIA, enthesitis-related arthritis, and polyarticular juvenile idiopathic arthritis. Why a polyarticular GIA? I'll be refuting the other differentials which I have stated in my last slide. The patient had involvement of 5 joints. They were fulfilling the criteria of juvenile idiopathic arthritis, and other differentials were ruled out. There was no history of an evanescent or transient rashes, which also rules out SOGIA. There was no family history of HLV-27 related diseases, no history of acute anterior uveitis, and no history of plantar fasciitis or tarsitis, which rules out enthesitis related arthritis. Now, the treatment history. The patient was treated as a case of polyarticular juvenile idiopathic arthritis and has received the following treatments. We started the patient on NSAID, that is tabnoproxen. Since there was no response to it or a reduced response, we shifted the patient to DMRD in form of methotrexate. We did start steroid as a bridging therapy. And lastly, we had to go to tocilizumab because the response was also not optimal with DMRD. Now he again presents to our institution with the complaints of difficulty in standing up from sitting posture for last 1 year. This was of insidious and of progressive in nature, onset and of progressive in nature. This was also associated with the swelling of bilateral knee joint, ankle joint, and sacroiliac joint. Furthermore, there was also stiffness of lower limbs, which got aggravated in the morning on waking up and got reduced on performing the daily activities. So my examination finding reveals in the general examination, the patient had got mild pallor, and the important negative ones are there was no baculopapular rash over the extremities and trunk. There was no generalized lymphadenopathy and no hepatosplenomegaly. Furthermore, the local examination of the bilateral knee and ankle joint reveals mild swelling, tenderness present. Local temperature was not raised. There was no contractures and no further reduced restriction in movements. And ophthalmological examination was also within normal limit. The important point reveals there was a weakness of neck flexors were present. Gower sign was positive. There were no skin rashes There were weakness of shoulder and hip girdle was noted because the patient also stated that he was not able to reach for high objects, he was not able to comb the hairs, and neither he was able to climb up the stairs and nor was able to stand up from sitting posture. Furthermore, it also revealed that there was no abnormality noted during fine movements of fingers, which rules out a kind of distal myopathy. So, are we dealing a case, two rheumatic diseases we have already noted, a myopathy and a GIA. So are we dealing something which includes both of these rheumatic diseases? It can be a case of juvenile dermatomyositis. The following differentials will be there, like juvenile dermatomyositis, overlap syndrome, or a polymyositis, or certain mixed connective tissue disorders. We did a panel of investigations, like first is the complete blood count, which showed a microcytic hypochromic anemia, which we get as one of the most common complications of the patients being treated as a case of GIA. Furthermore, the erythrocyte sedimentation rate was 15 millimeter at the end of first hour. Anti-nuclear antibody was positive. RA factor was raised, which is more than 50. The HLA-B27 was negative, and thyroid profile was also within normal limit. The muscle enzymes, as we see, was not elevated. EMG showed myopathy disorders involving all four limbs, and imaging we performed the X-ray of the lower limb, which showed no calcinosis present. So till now, what do we have in our hands? We have a history of bilateral symmetrical proximal myopathy, no rash, muscle enzymes not raised, EMG suggestive of myopathy disorders involving all four limbs. So we had a strong clinical suspicion that there might be that we need to rule out certain sort of differentials which I've mentioned previously, because none of them are fitting into the proper criteria, so what we have. So the strong clinical suspicion was there, and we did an MRI of the muscles of the thighs and legs. This is the MRI with the axial view, as well as the normal view is there, which shows the presence of hyperintensities. So the clinical suspicion was there, and finally we performed a muscle biopsy to rule out further differentials and to reach to a diagnosis. This muscle biopsy report shows a feature of dermatomyositis. There was dense lymphocytic infiltration around the perimyocele blood vessels with a perifascicular atrophy. Finally, what we have is now, we have a presence of shoulder and hip girdle weakness, as we deciphered from our history and an examination. We had the history of bilateral proximal symmetrical myopathy, the EMG showing myopathy disorders of all four limbs. There was MRI showing scattered areas of hyperintense signaling, and muscle biopsy stamping it as a case of dermatomyositis. So a diagnosis of juvenile dermatomyositis got established. Now, whether it's a case of JDM or it's a sort of overlap syndrome we have. Now, there is a clinical involvement of two rheumatic diseases, that is the juvenile idiopathic arthritis and juvenile dermatomyositis. Hence, we have diagnosed this condition as a JDM-GIA overlap syndrome. The autoantibody profile for the same has been sent, the reports of which are pending. So the outcome after the diagnosis of the JDM was made, the patient was given steroid at the rate 2 mg per kg per day. He was also given methotrexate and folic acid to treat GIA. On OPD follow-up, the myopathy and arthritis have reduced, and now he is able to carry out his daily activities. Now let's see some literature review. We have got some overlap syndrome case reports, one by Laxler and Sherry in the year of 2007, which has showed that such overlap syndromes does exist, and another case report by Sherry and Hashkes in the year of 2016, which showed that patients may remain with overlapping features for years, or their clinical picture may evolve into one or more of the classic CTDs. Another huge prospective observational study was performed in West Bengal itself over the period of 8 years, which showed that the overlap syndrome is defined by the presence of 2 or more rheumatic diseases, either on the basis of clinical involvement and or by autoantibodies. So conclusion, my case merits a mention because it's a case of JDM-GIA overlap, which is a rare entity. Any patient who's presenting to us with GIA and is having proximal myopathy, JDM needs to be ruled out, because if we treat both these conditions, then the condition of the patient can get improved. And furthermore, we have also emphasized in our case that there is certain role of MRI is existing, though it has still not been put under the Peter-Bogen criteria. It will help us to know which part of the muscles is getting involved, such that we can perform a biopsy. So that's all about my case. Thank you. was a non-erosive arthritis we have in SLE. We have a non-erosive arthritis in SLE. I just wanted to focus on the mixed connective tissue disorder part. Yes, we did. Yes, there was no skin rashes, and so there was not the typical Peter Bogan criteria was not being met. We are planning to manage. We already did put the patient on steroids to manage the per se of JDM, and we are also treating the case of JIA as well. We have to treat both the arenas together. And on follow-up, as I have mentioned, that the patient has now the myopathy and the arthritis have got now reduced, and he's able to carry out his daily activities. We'll put the patient on daily follow-up and monthly follow-up visits. And we'll also see that whether the patient is having any steroid toxicities or the patient is developing any resistance or suboptimal response towards the monotherapy. Then we can put on the further add-on drugs like methotrexate or hydroxychloroquine. Accordingly, we can manage that condition. Overlap do occur, sir. Yes, we had sent a profile for that. That's because we have two sets of autoantibodies. The autoantibodies which are specific for myositis and the autoantibodies which are associated with myositis. So the ones which are associated with myositis, like anti-ROLA antibodies, anti-Smith antibody, anti-RNP antibodies, if those are present, it increases the chance that there may be a case of overlap syndrome of the GI along with that MCTDs. On the other hand, if we perform the antibodies which are quite specific of myositis, it helps us to prognosticate the condition as well as it helps us to know the complications related to that, which includes like anti-P150 or P155 or 140 antibodies. We have anti-MDA5 and anti-Jo1 antibodies as well. Yes, specific antibodies for overlap syndrome. We have the antibodies. It may be associated. It is not included in the criteria, but we have sent the reports. It's still pending.
Thank you, Dr. Sampurna. Thanks to all for your kind attention. We are in the last case of today. Will be delivered by Dr. Pranjali Gothakurta. Her case on deja vu attack on cerebral clot. Dr. Pranjali.
A very good afternoon to all the respected delegates and my colleagues. I'm Dr. Pranjali Gothakurta, third year PGT MD Pediatrics of Archipel Medical College. Today I'm going to discuss about a spectrum of disorder with the help of two cases where similar episodes had occurred recurrently. So my first case was an 8-year-old girl who presented with high-grade fever of 4 days duration along with convulsion and altered sensorium. GCS was poor for initial 3 days. Initially, neck rigidity was positive and Brudzinski sign was also positive. She had marked bilateral lower limb hypotonia, DTRs were brisk, and bilateral plantar was extensor. Now, after ruling out the features of raised intracranial tension, we performed a lumbar puncture, which came negative for meningitis. From past history, we could elicit that she had a similar episode at 5 years of age where she presented with encephalopathy and abnormal dystonic movements. This was the MRI at that time. Now this time, the MRI brain showed hyperintense regions in T2 and flared at bilateral lentiform nucleus, caudate nucleus, and both subcortical white matter regions. So we had confusion between ADEM, Wilson's disease, or mitochondrial disorders at that time. So to rule out, we had investigated further. The serum copper, serum ceruloplasmin, and 24-hour urinary protein came all positive, ruling out the possibility of Wilson's disease. We performed MRI spine, which was normal, ruling out NMOSD and multiple sclerosis. So patient was diagnosed as the first episode of ADEM and was managed accordingly. Now this time, the new thing was there was patchy T2 and flare hyperintense areas in both subcortical regions along the white matter tract, suggestive of demyelination as shown by the MRI plate. So this case, we kept in mind multiple sclerosis, NMOSD, multiphasic ADEM. So to rule out the differentials, we performed a CSF test and oligoclonal band tested negative in the CSF. MRI spine was also within normal limit. Hence, based on the clinical decisions, we performed a blood test for MOG antibody, which came positive. NMO antibody, however, was negative. Hence, this time the patient was diagnosed as MOG antibody positive multiphasic ADEM. So, patient was treated with IVIG and IV methylprednisolone for 5 days. Symptoms started improving gradually. On follow-up, there is no further follow-up. No further recurrence in last 9 months as we had given azathioprine in this patient. Now my second case is a 8-year-old girl who presented with sudden onset difficulty in vision of left eye for 2 days duration. On examination, visual acuity of the affected eye was 6/60. There was disc edema present in this eye. Color vision was affected and features of relative apparent pupillary defect was also seen. However, other neurological examinations were within normal limit. So from past history, we could know that 2.5 years ago, she presented with ataxia, slurring of speech, and drooping of bilateral eyelids. MRI brain then showed demyelinating process of midbrain progressing towards pons, and features of 4th and 5th nerve palsy was also present. At that time, patient was tested positive for MOG antibody and negative for NMO antibody. MRI spine was within normal limit. Hence, she was diagnosed as first episode of ADEM. The recurrence first occurred on January 2020 with similar episode of ataxia, left-sided facial weakness. In both these episodes, she was treated with IV prednisolone for 5 days. This time, the diagnosis was made as MOG antibody positive multiphasic ADEM. Treatment with oral prednisolone and tablet azathioprine was started. Now, this time, the new thing was involvement of the optic nerves. VEP test even showed prolonged P100 latency, suggestive of demyelination type of dysfunction in retina-optic pathway. Oral azathioprine was continued, and this time, this was the MRI picture of the patient. And we had again the dilemma of multiple sclerosis, multiphasic ADEM, NMOSD, and other MOG positive disorders. So we performed the MRI spine, which was normal. Blood for MOG antibody, NMO antibody was sent. CSF for oligoclonal band came negative. Hence, she was diagnosed to have MOG positive MDEB optic neuritis. Now, the background story is acute demyelinating disorders of CNS are rare disorders. 2 antibodies play main role in case of demyelination process, namely aquaporin 4 antibody and myelin oligodendrocyte antibody. Now, we are discussing about MOG antibody, which is found in more than 1/3 of children with initial episode of demyelination, in more than half of patients presenting with ADEM, and positive in almost all patients with relapsing ADEM. Now, how to manage these cases? First, in case of acute presentation, we have to treat with IV methylprednisolone. If there is severe demyelination, we can go for plasma exchange and IVIG. After improvement, we can go to oral prednisolone, which is to be weaned over 3 to 4 weeks. Then we have to monitor. If again relapse occurs, we have to treat the acute episode. Then consider the maintenance therapy. If further relapse occurs, we can go for mycophenolate mofetil, azathioprine, or rituximab. If no relapse occurs for 2 years, we can stop the treatment. If further relapse occurs, we can go for monthly IVIG for 12 to 24 months. Now, overall prognosis of MOG and ADEM is usually favorable, with full recovery achieved in 60 to 96% of patients on follow-up. These are less relapsing and better long-term prognosis are seen in these cases. Now, my take-home message is acute demyelinating disorders of CNS are collectively rare. MOG antibody is positive in almost all cases of recurrent ADEM. Serial MRI of brain can be helpful along with specific antibody tests to clenching the diagnosis. Available treatment options should be considered to prevent the relapse, and long-term prognosis is better in MOG antibody positive patients than with other antibody positive cases. These are some of the literature reviews. Thank you very much. Yes. Sir, usually ADEM is monophasic, but if it recurs, that is more than 3 months interval after the initial episode, then we consider it as a multiphasic ADEM. Monophasic.
Thank you all.
Congratulations not only to the speakers but also to train them.
So everything was done. Our coordinator has done a lot of job for this. Dr. Pudipadi. So everything has done on his guidance only. ওর উপর দিয়ে অনেক খাটনি গেছে। So judges are in dilemma. Yes, judges are in dilemma. Yes.
Right, very eager. I don't think judging anybody will be good. They're all good. Should say nothing to be there. Get position right to be done right now. Really, even then they are being all equally similar. Even very good.
So pretty calm. So PT has got the first prize in the IAP presentation. Okay. Panjali second. once again, and so once again, and giving thank you to all of you. So IFP President Madam, we are also thanking you for your kind attention here. Okay, thank you. Rakesh, all the judges also, we are very much happy with you.
It's a card pen drive. Drive the car.
আমার পেন ড্রাইভ
যাচ্ছি।